Full text were 38 full texts were assessed. Okay, 38 full texts were assessed, and then 7 studies were included. Okay, these 7 studies were the randomized controlled trials conducting all across the world, and through these seven RCTs that we included 796 participants, and out of which 61% were females. Okay, so what were our results and what were the outcomes that we assessed? So these all were the outcomes that we assessed: response to treatment, IBS symptom severity score, improvement in diarrhea, abdominal pain, constipation, dry mouth, and tachycardia. All of the possible symptoms that we can see in patients experiencing IBS. So this is basically, we call it a forest plot. This forest plot tells us that what are the results. So for the treatment response, as you can see, this forest plot is for treatment response outcome. So we basically added all of these 7 studies. We pooled their data. Basically, in what we do in meta-analysis, that we take data from the primary studies and then we pool them, and then we get our own results out of them. So these were the 7 studies, and then we these were the events that happened, total patients events, and total patients in amitriptyline and placebo groups. And then we estimated their odds ratio, and according to that, you can see that here that our p-value is less than 0.05. That is the cutoff, as we all know, for it to be statistically significant. So our p-value was 0.001, less than 0.05. So in the treatment, so it was inferred that in the treatment response, amitriptyline was preferable to placebo. Similar was the case in IBS symptom severity score and improvement in diarrhea. The problem with the response to treatment outcome is that it is a bit subjective, but a lot of studies reported response to treatment outcome. IBS symptom severity score is a much better and objective criterion to assess the improvement in IBS. And similarly, there was decrease of abdominal pain and improvement in diarrhea. Abdominal pain was not statistically significant. As you can see that the p-value is 0.07. For IBS SSS, it was 0.02. And for the improvement in diarrhea, we can see that it is 0.004. So less than 0.05. For similar was the case with the constipation, dry mouth, and tachycardia. We took these 3 as the adverse effects and these 4 as the treatment response. Like these 4 are the efficacy outcomes, and these 3 are the adverse effects. And the adverse effects were non-significant, and most of the treatment response or efficacy outcomes were statistically significant. Okay, so through this slide we can infer that IBS has a very good profile when it comes to efficacy, and it is also very good as it is non-significant as compared to the placebo in terms of the adverse effects. Okay, so what was the problem with the response to treatment forest plot that I explained earlier? So as we can see, the p-value is less than 0.05, which is great. But the heterogeneity among all of these studies, it was really great. Because as we can see that these studies range from 1982 to 2023. So there were studies happening across decades. And it also introduced significant heterogeneity in our studies. As we can see that the heterogeneity was 66%. So we try to assess that what was the reason behind this high heterogeneity. If we're saying that amitriptyline is really great for the patients of IBS, then we have to explain this heterogeneity by some means, that why the heterogeneity is so high. Okay. So then we performed the sensitivity analysis. Upon performing the sensitivity analysis, we saw that omitting one of the trials, that was the Atlantis trial, the latest trial that was conducted, our heterogeneity dropped to 0%. So why was that? Basically, this trial, the Atlantis trial that I was talking about, it was conducted in England across their various states and published in the Lancet. So this was a really great trial, and it basically reported results on a very objective manner. Then we also performed a meta-regression to further clarify the reason for the heterogeneity. So we can see that there is a linear correlation between the odds ratio and the follow-up. For example, this study between Morgan, between the Raja Copeland study, and also the Atlantis trial. So the linear results show that the treatment efficacy may decrease over time due to factors like waning treatment adherence, resistance development, and or natural disease progression. And
Time.
can I have 1 minute just to complete this?
Okay, just conclude it.
Okay. So we also, in our meta-analysis, we also conduct risk of bias assessment. We saw that 3 studies were at high risk, at a low risk of bias, and 2 studies were at high risk of bias. Okay, what were the results? We saw that amitriptyline was well tolerated and effective in treating IBS as compared to the placebo across the 3 outcomes that I explained earlier. In responsive treatment, IBS, SSS, and diarrhea. And these findings support the use of amitriptyline for the management of IBS. And these are the few limitations that I wrote down, that there were 2 crossover trials. There were variation in the Rome criteria that I explained, that the Rome criteria evolved over time, that Rome 1, Rome 2, Rome 3, and Rome 4. So different studies used different version of Rome criteria. And then there was variability in the treatment periods, assessment tool, and one of the major problem was the lack of standardization and the lack of standardized outcomes used. So in future, these are all the future directions that future results can incorporate into their studies, especially when conducting research on IBS SSS, that they can see the dose-dependent effects of the amitriptyline in IBS, and they can also extend the treatment periods, use all IBS subtypes, and also use standardized outcomes. And thank you so much.
Thank you, Dr. Manahil.
Thank you so much. Any questions?
So we'll keep the questions for the end.
Oh.
Okay. So next is Dr. Mariam Arshad from Shaukat Khanum, Lahore. Her paper is titled "When Diagnosis Takes a Turn: A Case Series on Testicular Adrenal Rest Tissue, Leydig Cell Tumor."
Good morning, everyone. This is Dr. Mariam Arshad from Shaukat Khanum Hospital. I am working as endocrine fellow there. So I would like to talk about regarding when diagnosis takes a turn, TARTS versus Leydig cell tumor. So it is real diagnostic challenge to diagnose TARTS versus Leydig cell tumor. So I would like to discuss briefly regarding it. What are actually TARTs? These are benign intratesticular masses, and they are called testicular adrenal rest tissue or testicular adrenal rest tumors. And it is very difficult to differentiate them from other testicular masses. This is completely benign condition, and this is most common complication of congenital adrenal hyperplasia. Mostly 40% of individuals with congenital adrenal hyperplasia develop TARTs in their lifetime, usually from age of 8 years to 18 years. How TARTs actually develop. So during developmental phase, adrenals and testes are in close proximity to each other. So few of the adrenal cells lies within testes, and they can grow under influence of excessive ACTH that is produced in patients with CAH. They share close morphological and histopathological features with Leydig cell or germ cell tumors. So it becomes a diagnostic challenge for treating physician, that is usually the urologist. And why it's so important to differentiate these two entities? Because the treatment modalities differ. In TARTs, we usually treat with pharmacological therapy, that is steroid replacement, to keep ACTH levels to normalize them, causes shrinkage of tumors. But in Leydig cell tumors, there would be treatment of choice would be orchidectomy, that is surgical management. So it is very important to differentiate. If we misdiagnose TARTs as being Leydig cell tumor, we can offer unnecessary orchidectomies and can render patient to lifelong infertility. It is not cost effective. It has surgery-related side effects and social dilemma as well. So I would like to highlight briefly few differentiating features between two entities, but they overlap considerably. TARTs are usually bilateral, but few cases of unilateral cases have been reported. LCT is usually unilateral, but 3% cases of bilateral cases have been reported. There would be background history of CAH in patients with TARTs, but there would be no such history in Leydig cell tumor. Leydig cell tumor patients can have gynecomastia, but that is not very specific. Biochemical workup usually shows 17-hydroxyprogesterone, testosterone, and ACTH levels to be raised, but tumor markers will be raised into Leydig cell tumor or germ cell tumors, including LDH, AFP, beta HCG. When we move towards microscopic or histopathological features, TARTs in initial stages will be well circumscribed, rounded swellings with eosinophilic cell, less mitotic rate, clear fibrous septa, and apart from that, LCT will have high mitotic rate and atypical cell, but that is not very specific in advanced stages of TARTs. In advanced stages of TARTs, there can be intratesticular architectural distortion, so it can confuse the diagnosis. If we go towards particular staining, CD56 and synaptophysin will be strongly positive in TARTs, but it will be negative in LCT. Ranke's crystals are highly specific for LCT, but unfortunately, these are not sensitive. These are only 40%. These are only present in 40% of cases. So I have gathered few real-life cases from Shaukat Khanum Hospital that we encountered there. All of them had similar features, like all of them presented initially with bilateral testicular masses and were initially considered as cases of LCTs. Few of them were offered orchidectomies and few of them were saved from orchidectomies as endocrinologists reviewed them there. So first case is an 8-year-old boy who was diagnosed with congenital adrenal hyperplasia at age of 2 years. He was started on steroids initially, but he stopped taking his medications, and later on at age of 9 years he presented with bilateral testicular masses. Later on he underwent right-sided orchidectomy in tertiary care hospital and was diagnosed as case of LCD and was referred to Shaukat Khanum Hospital for contralateral orchidectomy. As he was known case of CH, so he was seen by endocrinologist in our hospital and was advised workup for CAH. That turned out to be positive, and he was labeled as having TARTs. He was started on steroid replacement, and his contralateral testicular mass shrink in size and showed positive treatment response, and now he's in follow-up with us. So he was actually saved from contralateral orchidectomy. So second case is 11-year-old boy, bilateral testicular masses for 1 year. History of precacious puberty was there. He underwent incisional biopsy.
Half time.
Okay. He had bilateral testicular masses and he had history of precacious puberty. Incisional biopsy was initially suggestive for LCT. As we initially talked, that histopathological features overlap considerably. So endocrinologist suggested steroid replacement for possible TARTs and he responded well to treatment. So he's having ongoing follow-up with us. Third case, regarding 30-year-old male, he had bilateral testicular masses. He didn't had history of CAH actually. He had subclinical CAH that was undiagnosed. So he underwent bilateral orchidectomies outside SKM and was referred later on for testosterone replacement to endocrinology clinic. Seen by endocrine team, ordered workup for CAH that turned out to be positive. He was given steroid replacement with aim to keep his ACTH levels in normal range to prevent pituitary hyperplasia. So in case 4, 9-year-old boy, classical CAH, he was diagnosed since infancy, but he was quite non-compliant with treatment. Hydrocortisone dose was never adjusted. His CAH was not biochemically controlled. So he developed bilateral testicular masses at age of 9 years. There was high suspicion of TARTs based upon his baseline history. So workup was done and he was labeled as having TARTs. Despite of this, urology saw the patient and proceed with unilateral orchidectomy. Histopath again created a confusion between diagnosis of TARTs and LCD. So based upon previous history, we labeled him as having TARTs secondary to CAH. And we started him on steroid replacement. He's again on follow-up with us. And his radiological imaging ultrasound has shown interval development or shrinkage of his testicular mass. So now I would like to conclude my presentation with few important points. TARTs with background of CAH must be considered as differential diagnosis in all patients who presents with bilateral testicular swellings. And every patient with bilateral testicular swellings should be referred to endocrinologists for assessment. It is worth noting that TARTs often exhibit a positive response to corticosteroid therapy. It is very cost effective and it should be differentiated from Leydig cell tumor. Overlapping histopathological features pose a challenge to conclusively differentiate between TARTs and LCD. However, clinical biochemical features at a diagnostic stage can help to reliably differentiate these two entities. Thank you so much.
Uh, Thank you for that paper presentation. Dr. Mariam, what is the duration of steroids that is recommended for these patients?
Okay, so patients has underlying CH, so lifelong steroid replacement is recommended for that because there is inadequate production of cortisol. The baseline mechanism is there is inadequate production of cortisol and aldosterone. Adrenal steroidogenesis is actually impaired. So we need lifelong steroid replacement to keep their ACTS levels to normal and to give adequate steroids.
And
So, were there any common findings to pick that diagnosis early for both of the
Yes,
studies?
previous history of CH, previous history of precocious puberty, virilizing signs. These are all signs we should we should carefully see in all patients with bilateral testicular masses.
do they require mineralocorticoid replacement as well?
Sometimes in there are a few subclinical cases which usually don't require, but when there is clinical cases of CH, they are usually diagnosed at infancy and they have absolute deficiency of cortisol and aldosterone. So they usually they can require mineralocorticoid replacement as well.
Thank you.
Thank you.
So next is Dr. Samar Minalla from SKM Peshawar. Is Dr. Samar here? Okay. So we'll move on to the next paper, which is by Dr. Irij Shehzad from SKM Lahore. The title of the paper is Clinical Manifestations, Antibiotic Sensitivity, and Outcomes of Pneumococcal Infections in Oncological Patients, Insights from a Single Center Perspective.
Assalamu alaikum, ladies and gentlemen. I'm Dr. Iraj Shehzad from Internal Medicine Department at Shaukat Khanum Memorial Cancer Hospital, Lahore. I'm going to be talking about the topic clinical manifestations, antibiotic sensitivity, and outcomes of pneumococcal infections in oncological patients, insights from a single center. Now, first of all, streptococcus, briefly just introducing the organism. Streptococcus pneumoniae is a gram-positive extracellular opportunistic pathogen that colonizes in the mucosal surface of the upper respiratory tract. Invasive pneumococcal disease can present in various forms, with bacteremic pneumonia, bacteremia, and meningitis being the most common, as well as the most lethal forms of clinical presentations in these patients. Streptococcus pneumonia has an extreme underlying genetic diversity with more than 90 serotypes in these patients, which makes it a leading cause of mortality and morbidity worldwide, particularly due to lower respiratory tract infections. When we talk about our own country, Pakistan is among the top 4 countries with the highest incidence of pneumococcal deaths. And Pakistan was estimated to account for 5% of the global pneumococcal deaths. There is limited data on the cancer patients for having pneumococcal infections. A study that was conducted on non-ventilator associated pneumonia in hospitalized patients with solid tumors showed streptococcus pneumonia as the most common bacterial pathogen, with 25% of the cases with this infection, and subsequent ICU admission, and which was a marker of poor outcome, which was linked to inappropriate empirical therapy in 10.6% of the patients. There is no data currently on cancer patients in Pakistan in this regard. So the reason we conducted this study was because streptococcus pneumonia has a significant but an underestimated burden of the disease. And as I showed earlier as well, while this disease has been studied in the general population, there is lack of focused research on the epidemiology, clinical presentation, antibiotic sensitivity, and outcome in cancer patients, particularly in the developing countries such as our own, where there is very limited data available in cancer patients. So the objective of our study was to review the clinical presentation, antibiotic sensitivity, and outcome of patients with pneumococcal infections among cancer patients. We conducted a retrospective study. It was descriptive in a single center study in Shaukat Khanum Memorial Cancer Hospital from January to December 2023. The variables that we studied included the demographics, that was the age and gender, the clinical presentation that included bacteremia, pneumonia, meningitis, and other causes, primary diagnosis, which was the type of malignancy, antibiotic sensitivities, and outcome, which included ICU transfers as well as mortality in these patients. So from January to December 2023, a total of 78 cancer patients were diagnosed with pneumococcal infection. Out of these, 2/3 of the patients were male, and most of the patients, more than 59%, were aged 18 and above. That is the adult population. When we studied the comorbid conditions in these patients, as expected, COPD and pulmonary diseases were most common in 9% of the patients, followed by diabetes in 7.7% of the patients. 3.8% of the patients had CLD, and only one patient was diagnosed with chronic kidney disease. On studying the primary oncological diagnosis in these patients, pneumococcal diseases were more common in solid organ malignancies, with 53.8% of the patients, and 44.9% of the patients had hematological malignancy. There was only one patient who had both a hematological and a solid organ malignancy. When we compared the different types of malignancy, all 35 of the patients out of the total 78 suffered from a hematological malignancy, with pre-BLL being the most common malignancy. This was followed by malignancies of the GI tract in 10 of the patients, then head and neck cancers in 7 patients, breast cancer in 6 patients. 5 of the patients had respiratory system cancers or bone and soft tissue cancers. 4 patients each were in genitourinary and nervous system, and 1 patient had a hematological and respiratory system malignancy, and 1 patient had a head and neck and genitourinary malignancy. On comparison of the clinical syndromes, the most common presentation was bacteremia with pneumonia in 43.6% of the patients, followed by bacteremia. Then there were other causes, which included otitis media, osteomyelitis, and streptococcal wound infections. 1 patient had bacteremia with meningitis, and 1 patient had bacteremia with pneumonia and meningitis. Then we studied the antibiotic sensitivity in these isolated strains. All the isolated strain of streptococcus were sensitive to ceftriaxone, penicillin, and vancomycin with 100% sensitivity. There was a 98.8% sensitivity in chloramphenicol. Levofloxacin had 97.4 sensitivity, clindamycin 83.3, while azithromycin and erythromycin and tetracycline had a sensitivity of 75.6, while the highest resistance was reported with cotrimoxazole with 74.4%. This slide shows us the importance that our strains were fairly sensitive to penicillin, ceftriaxone, as well as the macrolide antibiotics, as well as the respiratory fluoroquinolones. So this shows us we can use these antibiotics, as most of the patients with pneumococcal infections are treated empirically till we have the final culture results in these patients. The average length of stay for all the admitted patients was 3.68 days. Of these 78 patients, 12 of our patients were shifted to ICU during their admission. A total of, there was a mortality rate of 9 patients, and out of these 9 patients, 6 were the patients who were transferred to the ICU, which shows there is a higher mortality rate in the patients who were transferred to the intensive care unit. All-cause mortality in our patients was 11.5%. So to conclude our study, most of the patients with pneumococcal infections had solid organ malignancies, with GI, lung, and breast carcinoma being most common. Among hematological malignancy, pre-BLL was the most common presentation. Bacteremia associated with pneumonia was the most common presentation among our cancer patient population. And all our pneumococcal isolates were sensitive to ceftriaxone, penicillin, and vancomycin, while the highest resistance was shown with cotrimoxazole. And we saw higher mortality rates observed in patients admitted to the intensive care unit. The limitations of our study were that it was a retrospective study, so we did not see the patients in real time. It was a single center study, so we had a small sample size. We studied all-cause mortality in the patient, and the mortality did not include other causes of mortality in these patients. And the vaccination status of these patients was unknown. We all know that pneumococcal vaccine has been included in the EPS schedule of in our country as well from October 2012, but we did not know the vaccination status of these patients, which limits our study. So thank you so much.
Thank you. Do you have any question?
So, how did the clinical presentation of the pneumococcal infection in oncological patient differ from those with the normal conditions?
There was no particular difference in the patients. The patients with Streptococcus pneumoniae in our population also presented with clinical signs such as fever, cough, shortness of breath. On clinical presentation, there was Krepse, and in some patients had a radiological diagnosis of pneumonia. Although the presentation is the same, but our cancer population is more immunocompromised due to the treatment they are having, and as well as cancer being an immunocompromised state. So these patients were particularly more susceptible to these organisms, and bacteremia with pneumonia being the most common presentation, as well as the most common cause of mortality in these patients.
And
So
how
the,
about the severity
we did the
as
severe,
compared to the normal population?
as we studied the cancer population over here, but the patients with the oncological diagnosis, because they're immunocompromised, frequently presenting with febrile neutropenia and getting antibiotics off and on for various infections, more of multi-drug resistant organisms are found in cancer population as compared to normal population. However, we need to conduct more studies in which we should study a larger cohort, a larger multi-center trial, as well as study different serotypes of the patients to know about the actual sensitivity, and then we can work on from later on.
Thank you. Dr. Lal,
Thank
do you have
you.
any question? Okay, thank you.
Thank you.
Can I ask any question? You're welcome. So next up is Dr. Rehanullah Haseen from Shaukat Khanum, Peshawar. Okay, so I don't see anyone raising their hands. Next is Aminullah Abbasin, Aminullah from Abbasin University, Peshawar. Do we have anyone online maybe? No?
नहीं online.
Okay. Okay. Yeah. Next is cascading autoimmune conundrum, distal renal tubular acidosis and its complex interaction with Sjogren's syndrome, celiac disease, and hypothyroidism.
Yeah.
Comprehensive case report, Dr. Zainab Ajmal from Shaukat Khanum, Lahore. Zainab Ajmal.
Assalamu alaikum. I'm Dr. Zainab Ajmal, currently working as a endocrinology fellow at Shaukat Khanum Memorial Cancer Hospital. So today I will be talking about an interesting case which shows the complex relationship between renal tubular acidosis and Sjogren's disease. Also, in this case will be highlighting the importance of co-occurrence of multiple autoimmune conditions in a single patient. So just before I start with my case, I would like to briefly touch the topic of renal tubular acidosis, its types, its associations, and the underlying pathophysiology of renal tubular acidosis in patients with Sjogren's disease and other autoimmune conditions. So renal tubular acidosis is basically inability of the kidneys to effectively maintain the acid-base balance in the body. So we have metabolic acidosis classically, which is always normal A9 gap metabolic acidosis. So there are few types of renal tubular acidosis. Type 1 is always a distal defect. Type 2 is always a proximal defect. And there is type 4, which is due to aldosterone deficiency or aldosterone resistance. So talking about distal renal tubular acidosis, as I already mentioned, there is a defect in distal renal tubules where there is inability to excrete hydrogen ions, and in place potassium ion is excreted, and resultantly we have renal tubular acidosis manifested as metabolic acidosis with hypokalemia and a urinary pH which is always greater than 5.5. This is the hallmark feature which differentiates it from proximal renal tubular acidosis. So whenever we have a patient with distal renal tubular acidosis, there are many associations that needs to be considered for finding the underlying cause of renal tubular acidosis. There are many more, but I would like to touch the important ones here. So first of all, we always look for the autoimmune conditions like Sjogren's disease, as I mentioned, systemic lupus erythematosus. Further, there is association with hematological diseases like sickle cell disease, multiple myeloma, and many others. We should also consider hypercalcemia as the primary cause, and we should also consider urological diseases like obstruction in these cases. Last but not the least, we should also consider the effect of drugs and toxins in development of renal tubular acidosis. So I would definitely like to talk about the pathophysiology of renal tubular acidosis in Sjogren's disease. So as of now, the most widely acceptable pathophysiology for that is secondary to development of interstitial nephritis. But in our case report, we would like to highlight another possible mechanism that may be responsible for the development of renal tubular acidosis, which is the development of autoantibodies directly against the channels in the distal tubules. So let's start with the case. So a patient from Mardan, she was 51 years old lady, and she was referred to nephrology clinic for hypokalemia and metabolic acidosis. So the patient recently had right partial nephrectomy and histopathology was positive for clear cell renal carcinoma. So patient was evaluated and routinely the entire workup was ordered, including electrolytes, renal functions, urine routine examination, urinary electrolytes, and ultrasound KUB, and many more. So I'll be mentioning the significant results here only. So her blood test showed a pH of 7.26, bicarbonate of 7.6, potassium was 3.3, her urinary pH was 7, A9 gap was 13, and urine A9 gap was positive. So urine A9 gap was important because it actually differentiates the causes in normal A9 gap metabolic acidosis, which can either be RTA or diarrhea. So positive A9 gap shows that RTA was the underlying cause of the metabolic acidosis. So as I already mentioned, further workup to find the cause of renal tubular acidosis was done in that patient, including the autoimmune workup, which came out to be strongly positive. So patient's ANA titers were very high. Anti-SSA antibodies, anti-SSB antibodies, anti-nucleosome antibodies, and anti-CC antibodies were found to be strongly positive. So based upon the clinical features that a patient had and this strong positive autoantibodies, a presumed diagnosis of Sjogren's disease was made in that patient. We further decided to get the biopsy reviewed of the right partial nephrectomy sample that was available with us, and we reviewed the normal tissues surrounding the renal cell carcinoma sample. So the biopsy image is here, and we can see that it does not show any evidence of interstitial nephritis that I already mentioned should be, yeah, most understandably, should be the underlying cause of renal tubular acidosis in that patient. That further highlights the importance of the other mechanism that includes the involvement of autoantibodies directly affecting the channels in the distal tubules. So further making the case more interesting, after a few months, the patient presented to us with GI symptoms like postprandial epigastric burning, weight loss, and many other symptoms. So we ordered further workup for the patient, and it came out to be positive for anti-TTGs, anti-TTG IgAs were very elevated. We referred the patient to gastroenterology team, and we can see the biopsy report of it was a duodenal biopsy, which shows classical villus blunting and increased intraepithelial lymphocytes. So the diagnosis of celiac disease was made at this point. Further completing the entire autoimmune conundrum, thyroid function tests were significantly deranged and TSH was greater than 150. Ultrasound thyroid showed the background of thyroiditis in this patient. So yeah, patient was managed with soda bicarbonate tablets, potassium replacement was done. Patient was referred to a rheumatologist for management of Sjogren's disease. Further, she was referred to a GI specialist, and gluten-free diet was started. Thyroxine was also started in that patient. And currently, the patient is on follow-up with nephrology team. So the learning objectives that I would like to highlight from this case report. So we have multiple case reports showing relationship between Sjogren's disease and RTA, celiac disease and RTA, maybe Sjogren's disease and celiac disease. But the coexistence of all these four conditions in a patient is undoubtedly rare, but should be kept in mind that it can occur. Further, we would like to highlight the importance of less understood mechanism of development of renal tubular acidosis in patients with Sjogren's disease, that is due to the autoantibodies directly acting on the distal tubules. Also, whenever we have a patient with one autoimmune condition, we should definitely do a comprehensive evaluation and workup to diagnose the other coexistent autoimmune conditions, and it should be done in routine for every patient. Also, sooner we involve the other teams, the better it would be for the patient for the diagnosis of the coexistent conditions and resulting in the better outcomes of the patient. So thank you so much. That was about
Thank you.
my presentation.
So, Dr. Sabab, were there any unique markers that could help in early diagnosis of this complex interaction of RDN and autoimmune disease?
Yes, so in this patient, in addition to renal biopsy, we could have obtained the antibodies, which we can get with immunofluorescence testing could be done. But that was our limitation, that we did not do that in our patient, but we could have done that internationally. There are tests available via immunofluorescence in which we can directly, get those antibodies.
I mean, do we have anything that can predict actually, or you can have RDN, or I mean, a number of antibodies titers that can point out and guide you whether you are going to develop that condition or not?
That's what I'm saying. I'm saying that we can actually identify those antibodies directly. There is deficiency of hydrogen ion ATPase in such patients, and there are other antibodies against the intercalated cells that we can detect via immunofluorescence. And it can actually, predict early the diagnosis of renal tubular acidosis in such patients. Because there are also case studies which show that interstitial nephritis develops at a later stage, and renal tubular acidosis develops way before than interstitial nephritis.
Thank you.
Thank you.
Okay, we have another paper from Shaukat Khanum, Peshawar, Dr. Farhan Ali. Do we have Dr. Farhan with us? No. Okay, moving on to the last one is which is by Dr. Hajra Nisar. She will be presenting comparative analysis of four risk factor calculators for predicting myocardial ischemia during immediately after surgery over the past decade at a cancer hospital.
Bismillahirrahmanirrahim. My name is Dr. Hajra Nisar Jima, resident internal medicine at Shaukat Khanum Memorial Cancer Hospital. The topic of my study was comparative analysis of four risk factor calculators for predicting myocardial ischemia during and immediately after surgery over the past decade at a cancer hospital. Okay, worldwide, more than 10 million patients experience serious cardiac events after non-cardiac surgery. As per literature, perioperative MI is the third leading cause of death in US. That means it is secondary to stroke, ischemic heart disease. So far, there is no data available on this subject in Pakistan. As per the fourth universal definition of MI, it is defined as the characteristic rise and fall in the cardiac troponin levels with at least one value that is above the 99th percentile of the upper reference limit of normal. That is greater than 0.014 nanogram per ml with at least one of the following features. That is ischemic nature of chest pain, recent significant ECG finding such as ST and T wave chain alterations, new onset left bundle branch block, or the presence of Q waves, new onset regional wall motion abnormalities on echocardiography, and demonstration of an intracoronary thrombus on angiography or autopsy. Now, various predictive tools have been developed and adapted over the time to better forecast the risk of such events. These tools aim to enhance the ability to identify high-risk patients and improve perioperative care, ultimately mitigating adverse outcomes associated with myocardial infarction. Our study aimed to determine the usefulness of these risk factor calculators in predicting MI in cancer population. This study retrospectively analyzed the data from the past decade, that is 2012 to 2023, within a cancer hospital setting. It focused on patients who experienced STEMI or NSTEMI during or immediately following surgical procedures. To assess the risk of MI, 4 established risk factor calculators were used. That included Revised Cardiac Risk Index 1999, American College of Surgeons National Surgical Quality Improvement Program, that is ACS NSQIP, Surgical Outcome Risk Tool version 2, and American University of Beirut has 2 Cardiovascular Risk Index. The keywords that were used to screen such patients included ACS, acute coronary syndrome, anterior wall MI, lateral wall MI, inferior wall MI, STEMI and NSTEMI in handover note. Total patients that were screened include 1,925 patients, and out of which total patients who had MI that were admitted in ICU were about 115. And the patients who underwent MI in perioperative period in this time were 18. Now, most of our patients, that is about 78% of our population, had NSTEMI, followed by anterior wall MI, while a few patients had inferolateral wall MI and type 2 MI. Now, the risk factor tools we used showed that SWOT version 2 and ACS NSQIP were the poor indicators of adverse cardiac outcomes in our population, while the AUB has-2 score predicted only 5 patients, and the RCRI, that is the Revised Cardiac Risk Index, predicted a much higher proportion of patients. So in our study, Revised Cardiac Risk Index identified only 8 out of 18 patients who experienced cardiac events as class 3 risk, with 2 patients classified as class 4 risk. The AUB has-2 cardiovascular risk index, which is noted for its strong discriminative ability in predicting composite outcomes such as all-cause mortality, stroke, and myocardial infarction within 30 days after surgery, predicted only 5 patients as high risk. The ACS NSQIP, which incorporates about 20 patient predictors, that is age, ASA, BMI, ASA class, BMI, hypertension, and the planned procedure, that is the CPT code, to estimate the likelihood of 19 different outcomes within 30 days post-surgery proved to be of limited utility in our population. Similarly, SWOT version 2 tool also underestimated the risk of adverse cardiac events in our group. Now, the RCRI, that is the Revised Cardiac Risk Index, uses the following parameters in predicting such events. That is elevated risk surgery, which includes intraperitoneal, intrathoracic, suprainguinal vascular surgery, history of ischemic heart disease, that is patients whose ECG shows pathological Q waves, history of previous MI and a positive exercise tolerance test, history of congestive cardiac failure, which includes patients who had a history of pulmonary edema, S3 gallop rhythm, and the evidence of pulmonary vascular redistribution X-ray. History of cerebrovascular disease, which includes a patient who had a history of TIA or stroke, and preoperative treatment with insulin and preoperative creatinine of greater than 2 milligram per deciliter. As per RCRI score, if a patient has score of 0, 1, 2, or greater than 3, they had a risk of major cardiac event of about 3.9, 6, 10, and 15% respectively. So the conclusion of our study was that though RCRI has predicted adverse cardiac events in about more than 50% of patients, but no single tool can be relied on. Factors such as cancer type, functional capacity, and the importance of comprehensive clinical history and examination should never be overlooked. The limitations observed in current tools underscore the need of continued research into additional parameters such as calcium scoring, preoperative troponin I, and BNP levels, as well as the development of new risk indices to improve prediction accuracy for adverse outcomes in perioperative setting. Moreover, I also want to highlight that this was not the sole objective of our study, and we are studying about 10 different parameters also that includes the age, preoperative troponin I, the type of chemotherapy, gender, type of cancers in this patient, and this is a continued research that is going on. Thank you.
Thank you. Dr. Haja, so you mentioned that the RCRI predictor, it still missed a lot of patients. The patients that were missed, did the other predictor calculators pick those up?
No, they were not picked by the calculators, as the patient who had a very high risk were picked by the other calculators, and about the remaining proportion of 50% of patients were not picked by any of the calculator.
Okay. did any of the, because we give a lot of chemotherapy, did any of the calculators have chemotherapy listed as one of the risk factors?
No, there is not only a single calculator that uses the criteria of chemotherapy. That's why this is an ongoing research that we are conducting to know that if a certain chemotherapies have effect on predicting such events or not.
Okay. What about, a lot of patients have, type 2 MIs, where they might not have atherosclerosis, but, they have maybe ongoing sepsis, anemia. Did the calculators take those into account, type 2 MIs?
Out of our population, only one patient had type 2 MI, while the remaining had NSTEMI. Majority of them had NSTEMI followed by anterior wall and infralateral wall MI.
Did all the patients have an angiogram?
No.
So
Some of them had it, but some of them are under workup with cardiology team and are also on follow-up.
so they had any proof of coronary artery disease? Did they have any
Yes, some
proof?
of them had the evidence of ischemic heart disease, and out of our population, about 50% had a prior history of ischemic heart disease.
So, were there any factors that actually consistently overcalculated the risk?
Actually, we had, as per our study,
Overestimated, I must say.
more of our risk was actually underestimated rather than overestimated, because it may be due to the background history of cancer, the background of chemotherapies, or the background of functional capacity.
Thank you.
Welcome.
So we still have the papers from Shaukat Khanum Peshawar. It doesn't look like anyone has shown up. Dr. Samar Minella, Dr. Rehanullah Haseen, Dr. Aminullah, Dr. Farhan Ali. Okay. So, right. So we have lots of time for questions. So if we can open the session for questions from the audience.
Excuse me, sir. Am I audible?
Right. Thank you very much. My question is from Minahil, the final year student, only student brave enough to be here at 8:30 a.m. while some of our own didn't bother to show up. So well done. I'm sure you'll have a
Am I audible?
bright future. The question is, you've done a meta-analysis on IBS. What is the finding from Pakistan? Did you find a paper from Pakistan about IBS? And do our physicians prescribe
Excuse me,
amitriptyline?
sir. Am I audible?
Thank you. Thank you for the question. Actually, the 7 included RCTs. None of them was conducted in Pakistan, and this is a major gap that we can cover in Pakistan to conduct more research on IBS. And there was one study from Iran that is the most close to our geographical area. The rest of the studies were conducted in US and in Europe and in other parts of the world. And sorry. We know what is the incidence in Pakistan. Actually, the focus of our meta-analysis, it was very narrow. That is to assess the efficacy of amitriptyline in the patients of IBS. IBS, as we know, is a very broader topic, and it is a proper subtype of in the gastro department. So our topic was very narrowed. That was the efficacy of amitriptyline in IBS. There is tons of study conducted on IBS in Pakistan, and I also mentioned one study that shows that there is a prevalence of 13% is the prevalence of IBS in Pakistan. So that was a study conducted in Karachi, and there are multiple other studies on other focuses of IBS, but not amitriptyline or the efficacy of IBS. Thank you.
Any other questions? Okay.
Excuse me, sir.
Because I can hear someone speaking in the background.
Excuse me, sir. Am I audible?
Yes. Who is that?
Sir, I'm Dr. Laiba Ahmed from Peshawar. I have joined on Zoom.
Progress.
Sorry, I didn't catch that. What's your name?
Sir, I am Dr. Laiba Ahmed, and I am presenting on behalf of Mr. Aminullah from Abbasin University.
Okay, all right, great. So your paper is titled Sustained Virological Response to Antiviral Drugs in Treatment of Different Genotypes of HCV Serotic Patients.
Yes, sir, exactly.
Okay, all right, go ahead.
Okay, sir. Assalamu alaikum, everyone. So I'll be presenting my research, which has already been mentioned. It was published in Pakistan Journal of Pharmaceutical Sciences in May 2023. So we'll move towards the presentation outline. It has introduction, objectives, materials and methods, plan of our research, the results, the conclusion, and finally the references. So why HCV as a topic for research? Because it's a major...
Hold on, sorry, we can't see your presentation. Did you send in your presentation?
No, sir. They actually hadn't asked me. They just shared the link for joining in the meeting.
Can you share your screen?
Yes, sir. I have already shared my screen.
Can we technical team maybe help out?
Yes, sir. Hello.
The technical team is trying to get you to share the screen.
Okay, sir.
Can I get your full name?
Sir, my name is Dr. Laiba Ahmed.
Laiba Ahmed. I think apparently the presentation is visible on the app. If
Yes.
everyone can maybe log in on the app, then we can possibly proceed. Does everyone have the app? I think the Shaukat Khanum residents probably do have it, and we can possibly share, with the non-Shaukat Khanum. You can actually download it if you haven't already. Okay, all right. So we have the presentation up and running. Dr. Laiba, can you hear me?
Yes, sir, I can. Should I
Okay.
proceed?
Can we enlarge it maybe a little bit, zoom in a little bit? Without cutting the sides.
Sir, is it visible now?
I think you should start the presentation.
Okay, sir. Assalamu alaikum, everyone. I'm Dr. Laiba Ahmed, and I'm here to present my research titled Sustained Virological Response to Antiviral Drugs in the Treatment of Different Genotypes of HCV Serotic Patients. This research was published in Pakistan Journal of Pharmaceutical Sciences in the year May 2023. So I'll move towards the presentation outline, which consists of introduction, objectives, the materials and methods, the plan of our research, the results, the conclusion, and finally the references. So why HCV as a topic for our research? Because HCV is a major health concern in Pakistan with around 10 million people infected, making it the second most affected nation globally. HCV is a leading cause of chronic liver disease, progressing to cirrhosis, fibrosis, and liver cancer, with a 50% 5-year survival rate for liver cancer patients. HCV remains a significant threat. HCV has basically 7 genotypes and 67 verified subtypes, making genotype identification crucial for effective treatment. So previously, the traditional therapies like pegylated interferons and ribavirin are often inadequate, especially in cirrhotic patients. However, the advent of direct-acting antivirals, also known as DAAs, particularly sofosbuvir and declatesvir, has transformed treatment protocols. These agents have demonstrated promising efficacy, including a sustained virological response or SVR in various HCV genotypes. So our study explores the effectiveness of these combinations in treating various genotypes of HCV in cirrhotic patients in Khyber Pakhtunkhwa, particularly in Peshawar. So the main objectives of our study were to firstly to assess the sustained virological response or SVR rates of direct-acting antivirals such as sofosbuvir and declatesvir with or without ribavirin in HCV cirrhotic patients. Secondly, to evaluate the effectiveness of sofosbuvir plus declatesvir and sofosbuvir plus declatesvir plus ribavirin across different HCV genotypes, including the mixed and untypable genotypes. Thirdly, to compare the SVR rates among patients in compensated and decompensated stages of liver cirrhosis. Thirdly, to identify the various Okay, next I'll move towards the materials and methods. So the study design, actually it was a prospective study. We had 190 HCV cirrhosis patients which were admitted in the public sector hospitals in Peshawar, particularly HMC and KTH in Peshawar. The duration of our study was from 2019 to 2021. We got the ethical approval for our study from Cobam Ethics Committee, University of Peshawar, and we also had the informed consent obtained from all the participants. We collected the blood samples, which were stored at minus 80 degrees Celsius for analysis. We extracted the RNA using QI-AMP viral RNA mini kit. The complementary DNA synthesis, since HCV is an RNA virus, was conducted with Bioron life science kits. All of these are the instruments which are used for the genotyping of HCV. 2 rounds of PCR, 35 cycles each, product visualized on the agarose gel. For HCV genotyping, multiplex PCR was used, whereas for viral titers or viral loads, we used real-time PCR. So we used SPSS version 25 and Microsoft Excel 2018 for statistical analysis, and the various measures of central tendency and variation were shown by this statistical analysis. So basically, the plan of our research was that the patients were grouped by gender, genotype, and treatment. The first group, they received 2 drug combinations, sofosbuvir and declatesvir, daily for 12 weeks, whereas the second group, they received 3 drug combinations, sofosbuvir, declatesvir, and ribavirin for 24 weeks. Obviously, those patients with HB levels or hemoglobin levels less than 10 or anemic, they received larger RBV doses or ribavirin doses, whereas also the patients with weight having less than 75 kgs, they received 1000 mg of antiviral drugs, whereas those over 75 kgs, they received 1200 mgs. And all the groups, they calculate SVR rates after 12 weeks and 24 weeks. So the fresh samples underwent the liver function test and quantitative PCR, which were used as the markers for treatment response. So we have the demographic characteristics of those 190 patients. They were grouped by gender, age, child Turkic scoring, ALT levels, AFP levels, the bilirubin levels, the albumin, and the viral load. We also classified these patients according to the genotypes into 1A, 1B, 2A, 3A, 3B, mixed and some untypable strains. So then we got the results. The results were as group 1 had 74 patients. Out of 74 patients after 12 weeks, 66% achieved undetectable HCV RNA, whereas after 24 weeks of treatment, 83% achieved sustained virological response. Similarly, in group 2 patients, 60 patients were there. After 12 weeks, 73% had undetectable HCV RNA, whereas after 24 weeks, 86% achieved SVR. But 14%, they unfortunately experienced severe complications, including anemia and ascites, particularly in the decompensated stage, which was particularly due to ribavirin, which is known to cause side effects such as hemolytic anemia, and it is also teratogenic. The third group, which who received sofosbuvir plus ribavirin, had 56 patients, and after 12 weeks of
Yes, sir. Sorry, I guess there are some network issues here. I'll reshare my screen.
Okay.
So we'll resume.
Yes, if you could start from the slide where we left off,
Yes, sir.
where you had the technical problem.
Yes, sir. So here are the results for group 1 patients who received the 2 drug combinations. There were a total of 74 patients, out of which at the end of 12 weeks, we had 49 patients as HCV negative, whereas at the end of 24 weeks, we had 62 patients as HCV negative, which was done using real-time PCR and a liver function test. For the second group, we had a total of 60 patients, out of which at the end of 12 weeks, we had 44 patients who were HCV negative, whereas at the end of 24 weeks, we had 52 patients which were negative, which is the maximum response rate amongst the three groups. For group 3, we had a total of 56 patients, out of which at the end of 12 weeks, we had 3 patients who were HIV negative, whereas at the end of 24 weeks, we had about 47 patients who were HIV negative. So you cannot see the screen. Okay, so here's the pie chart representation of all our results, showing the same results as discussed earlier. So here's the comparison of various percentages of response to different genotypes among the 3 different treatment groups. For group 1, we can see that 83% were responders at the end of 12 or 24 weeks, whereas for group 2, which were given a drug combination, 86% of the patients were responders at the end of 24 weeks, whereas for group 3, who received the 2 drug combinations, Sofosbuvir plus ribavirin, 84% of the patients were responders of 24 weeks. So we can see here that 3 drug combination was highly effective in reducing the. Hello?
Dr. Laiba, we can hear you.
Okay, sir. Okay, here are the 3 or the complications in the various treatment groups. We can see that the maximum number of complications were seen in those groups, particularly in this group 2, declatacey and ribavirin, and the group 3 patients who received sofosbuvir and ribavirin. Here's the complete summary, and the complications were anemia, ascites, and arthralgias. Finally, the discussion. In our study, the highest sustained biological response rates were observed, 63 to 66% at 12 weeks, increasing to 83 to 86% at 24 weeks, especially in genotype 3 patients, which is the most common and drug-sensitive genotype in Pakistan. However, the patients receiving ribavirin experienced more side effects, including anemia and fatigue. Despite these challenges, DAAs or direct-acting antivirals remain highly effective in treating HCV across different genotypes and stages of liver disease. So our conclusion was that patients with HCV genotypes were successfully treated with sofosbuvir plus declatacey with ribavirin for 12 and 24 weeks, according to the research. Regardless of the treatment duration or the addition of ribavirin, the SVR rate substantially increased in patients in group 2. So finally, when sofosbuvir and declatacey are used along with ribavirin, they perform far better than the control group. Therefore, therapy with sofosbuvir with declatacey along with ribavirin is more effective for treating the patients with HCV, despite regardless of their genotype. But the most response was there in the HCV genotype 3 patients. Here is a screenshot of our published research article, which is in Pakistan Journal of Pharmaceutical Sciences, and here are the references. Thank you.
Thank you, Dr. Laiba. Unfortunately, the presentation was, marred by multiple technical issues. From what I was able to gather, this was a prospective study, and there was a group which used. Sorry, Dr.
Yes,
Laiba,
sir. Yes,
you hear me?
yes, sir. Yes, sir,
Okay.
I can hear you.
So, can you hear me?
Yes, sir, I can hear you, but the
So
signals
I
are
said,
better.
this is a prospective study, and you said there was a group of patients who
Yes,
got three different drugs, right? And there were certain patients that actually passed away during the study.
Yes, sir.
So what was the mortality comparison between
No,
the
sir.
three?
Actually, first, sorry, sir.
I said, what was the mortality rate between the 3 groups?
Okay, sir. So the treatment response was that 86% of the patients who received group 2 combination, which was for 3 groups, 3 drugs, sofosbuvir, ribavirin, declared cancer, they had the maximum response, 86%, and the rest of the patients unfortunately died and had a mortality rate of about 14% in group 2 patients, whereas in group 1 patients, 82% of the patients were effective, and the 18% were actually they passed during it. Whereas in group 3 patients, 84% of the patients who received group 3 treatment, they were successful in being treated, whereas the rest of 16%, they actually passed away during our study.
Was the mortality due to side effects of the drugs, or was it because of cirrhosis?
So it was actually due to a failure of treatment and also due to the stress which the patients suffered during the treatment, and particularly the patients received.
What was the main cause of mortality in these patients?
So it's because the patients who were actually being studied in this research already had this full-blown cirrhosis, and they were not only positive for HCV, but they also had cirrhosis in them. So, sir, actually they progressed to a decompensated liver cirrhosis, and they passed away during our study.
Okay, all right. Dr. Harris, do you have any questions? Okay, all right. I think with that, we don't have any more. If we have any questions from the audience about this paper. Okay, all right. So with that, we'll conclude the session. Thank you everyone for joining us.